Hi, everyone. Welcome to our June reimbursement webinar. This is Luana Bossolo with the APA Practice Organization. I would like to welcome our two speakers today, Dr. Antonio Puente, President of the APA and the Practice Organization, and as well as Alan Nessman, who's a lawyer here in the Practice Organization. Very quickly, today we're going to cover all of your questions. We received several hundred questions from everyone who registered for the webinar, and we received questions from our May webinar as well. So we're going to cover things around insurance, Medicare, crisis codes, health and behavior codes, some specific CPT codes that you all asked about, as well as testing and evaluation. So with that, I would like to turn this over now to our presenters, Alan Nessman and Dr. Puente. Alan?
Welcome, everyone. As you see, we have disclaimers for you in case you're having insomnia. There's a long disclaimers to read. For the Practice Organization disclaimer, it's really pretty simple. We can't give legal advice to you as members, and legal questions are too complicated and fact-specific to cover in this kind of format. The answers I'm giving are going to be much shorter versions of what we typically say when we're talking to members and providing our views on these issues. Tony?
As for myself, first of all, I want to welcome you to the second of our two seminars. But as far as this particular disclaimer, please note that Alan's disclaimer is good for insomnia. Mine is a cure for coma. And specifically, it's a very big comment that we are going to provide the best information possible, but in many ways, the ultimate responsibility to address each of these codes and your own particular circumstances lies with you. This is aspirational, the best information we can provide, and we hope this gives you some guidance as you proceed further into this very complicated billing, reimbursement, and documentation world. Again, welcome. Look forward to being with you for the next hour.
All right. So the first question is, what supports do we need to provide to use or justify billing the code 90837, which, as everyone knows, is the 60-minute therapy code? If the insurance company questions 90837 usage, how do we respond? Okay, so I have several parts to this answer. The threshold question is, does the company allow the use of 90837 without restrictions? Assuming that the answer to that is yes, then we're dealing with a situation where either the company suggests or you're just concerned that the company might audit you if you're using 90837, particularly if you're using it a lot. So the first thing to look at is the CPT manual. Have you spent 53 or more minutes with the client in therapy? Then the second question is, look at the practice organization guidance. Are you recording your stop and start times? Okay, beyond that, and first I just want to say, some companies like Anthem, Blue Cross Blue Shield, Highmark, Blue Cross Blue Shield, and Medical Mutual in Ohio have assured us that they just want to make sure that psychologists are properly using the codes and recording their start and stop times as the practice organization recommends. Beyond that, you want to see if the company has given you any additional guidance on what they expect for billing or documentation when you're using the 90837 code. So you can check the provider section of the company webpage or check provider updates that they send you. I realize sometimes they send you a lot of stuff, and if you're dealing with several companies, that may be a lot of stuff. If you're unsure, you might just check with your provider representative and see, is there any other guidance? Note that if the company hasn't warned you that they're interpreting 90837 more narrowly than is written in the CPT code, they don't legally have a good ground for objecting to your use of it if you're using it properly, but that doesn't always stop auditors. So the next thing to think about is, here's some other things some strategies you might want to think about. We know that some members use 90837 almost all the time for therapy, and they have a right to do so if they're using the code properly per the CPT guidance and the company guidance. But if you're one of those psychologists, you might want to consider using 90834, the 45-minute code, in some of your more routine sessions and with your less difficult clients. And then you would be documenting in your more difficult cases with your more difficult clients that these are more complex cases, there's a lot going on, you know, the clients are having difficulties, you might just want to say something about why with this client or with this session you're spending more time. And we know that some members specialize in high-need, difficult patients, and in that case you just want to be documenting that these are difficult patients that you're dealing with. Thanks.
Let me add to that,
next,
and let
sure.
me specifically emphasize the word properly. Just because you think it's proper, or if you will, you think that meets the concept of medical necessity, it may not necessarily be the case. I want to emphasize three things that Alan has shared with you. Number one, is this the case that you've seen this information in the company guidance manual? Number two, does this fit the requirements for the code descriptor in the CPT system? And number three, there must be documentation that emphasizes the unusual nature of this particular procedure. The standard procedure historically and still now is the 45-minute intervention. So unless you have something unusual, patient is difficult, there's difficulties in communication, they're coming from far away, etc., it is best to consider the standard psychotherapy code. So what does CPT say? What does your company say? And three, what does your documentation say? Thank you, Alan.
Mm-hmm. So the next question is, why do some insurers refuse to pay for 90837, i.e. reimbursing at the same rate as the 90834 rate, while other insurers compensate for the difference in time? Well, as I said in the last webinar, insurance companies have tried a variety of different tactics to reduce providers' usage of the 90837 code. Some of them say it's substantially increased their cost to be paying more for the longer code, which is now much more available than the old 90808, which was for 75 to 80 minutes and therefore rarely used. So one of the strategies and one of the tactics is to just not pay any difference between 90834 and 90837, essentially saying, sure, you can use it, but it's not going to benefit you because we're not going to pay anymore, or just not paying it at all. And that's one of the easier tactics for us to challenge if parity applies. And essentially the argument is, tell us what codes on the medical surgical side that you're not paying a differential for. And the obvious comparison is the E&M office visits, which, like therapy codes, are on a graduated scale of intensity and time. So we've gotten Aetna, Anthem Blue Cross of Colorado, and Regents Blue Cross Blue Shield to pay a differential using these parity arguments, although we still have a complaint against Regents in Utah about how much the differential should be. We also have a complaint against Independence Blue Cross in Pennsylvania, and we just sent inquiry to Florida Blue and its carve out new directions because they've just started doing that recently. So this is something that we've had some success challenging, and we're currently challenging this in some places, and we're hoping to get all the companies off of that tactic.
Appreciate the fact that the difference between 3.4 and 3.7 in the valuing process of the CPT system is substantial. So at the Medicare level, these are different codes in terms of description, in terms of time, and in terms of value, the RVU or RUC value.
Okay, we had another question about the 90837 policy by Optum, UBH, and United Healthcare. Essentially their policy is that they're only routinely allowing 90837 for 3 diagnoses: PTSD, panic disorder, and OCD disorders. The analysis of this policy is more involved than we have time to get into today, but if you send us an email to the email at the bottom of the screen, which is also very simple, it's just practice@apa.org, and just say Optum 90837 policy, we'll send you an analysis of that policy. Just too much to get into in the time we have here today.
All right, Alan. Let's move on to our next slide.
And these are for you, Tony.
All right. So first of all, these are associated with testing codes. And how do we use the standard 101 and the 118 neuropsych testing when conducting ADHD evaluation? Well, I think the answer lies in probably the diagnosis. First of all, whatever diagnosis you use really makes the decision for you as to what kind of code you end up using. If it's a, quote, DSM, or if you will, Chapter F of the ICD system, or if you prefer Chapter 6 in the upcoming ICD-11, you probably be using a 96101 code. On the other hand, if you have a situation where the evaluation emphasizes a neuropsychological condition and maybe a code outside of these particular chapters of the ICD, the appropriate code may be 96118. In other words, the bottom line is, what diagnosis are you searching for or you're testing for? That would determine which one. Caveat, don't use both. It's not in your best interest to mix. These things come across as silos. In other words, psychiatric interview goes with psych testing, neurobehavioral status exam goes with neuropsych testing, and it's best that you don't mix those two silos together, at least in the procedural aspect of your evaluation. Can 96101 be used for an evaluation consisting of a structured clinical interview and questionnaires? Well, the answer is it shouldn't be used, and it's really difficult to answer this question because the first phrase that we have in this question is structured clinical interview. The noun is interview. So as a consequence, if it's an interview, you should be considering the psychiatric interview code. If, on the other hand, you're doing an presenting of questionnaires that provide some kind of norm reference or, if you will, numerical value, then it's in your best interest to consider 96101. So it's a long-winded way of explaining very simply. If it's interview, use the interview code. If it's testing, use the testing code. The next question is a bit more of a challenge. How to address the difficulties of building mental health codes for medical issues such as pre-surgical evaluations. And in this case, the individual has provided two codes, 90791 and for that matter, 96101. Well, let me suggest the following. First of all, the best codes for, quote, medical issues are your H&B codes. I would stay away from your mental health code because in this particular situation, you're going to be, for example, using the diagnosis of obesity, which matches the health and behavior codes and do not match the mental health codes of 101. So again, as I've shared with you in the other two questions that we had in this particular slide, the diagnosis drives the type of evaluation, or for that matter, the type of codes you end up using. But this is a particular challenge. Let me ask another question, which is, if you will, associated with this. What if my insurance company forces me to work inside of a carve-out, despite the fact that I want to use a medical diagnosis? Well, you have to be bound by the contractual arrangement that you have agreed to. If they say you have to use a code that does not seem to be appropriate, just look carefully for the guidance that they've provided and work within the boundaries of your contractual arrangement. If you think that's not appropriate, use others, whether it's the APAPO, your state association, to try and educate the insurance carrier as to more appropriate billing and documenting for that particular situation.
And Tony, I would add something on that.
Yes.
What we always tell people, if an insurance company or other payer is telling you to do something that you consider unusual or inappropriate in terms of coding, that's their right to, ask you to bill things differently, but we always recommend that you confirm that in writing. Now, getting a writing back from an insurance company is pretty hard to do, but the easy thing to do is to send a confirming email to the company. So you just say, this is, to confirm that you have told me to use these codes. That will protect you in a situation where 5 years later or 2 years later, somebody else at the same company is saying, why do you bill this way? And you don't want to be in a situation where, some nameless employee who may not be there anymore told you to do it, you have this confirmed in writing, and that's the easy way to do it. Send a confirming email to the company to just protect yourself in case somebody later changes their mind about whether that's appropriate.
It's all about documentation, Alan. Correct.
Yeah.
All right. I think the next set of questions really belong to you.
Okay, so the next question is, how far back can an insurance company take back money? We were just asked to give back money from payments 4 years ago. So the answer is most states have what are called recoupment statutes, also called clawback statutes, that limit how far back a company can go in collecting those kind of payments. Most of those statutes set the limit at 1 or 2 years. A few have less than a year, a matter of months. 4 years sounds very long. A longer period might mean that it's a self-insured plan, which many large employers have. And these self-insured plans are subject to ERISA instead of state insurance laws. Now, that might actually be helpful because we know some class action attorneys we've talked to, and they won some cases, for example, 2014 Illinois case, where what they won was a court determination that the company under an ERISA plan can't do like most private insurers do, which is just say, okay, we've looked, we decided that you owe us X amount of money because of mistakes that you, or typically mistakes the insurance company or the employer made. They actually have to go through the full ERISA procedure of issuing new benefit determinations, demonstrating the overpayments, and complying with ERISA claims and appeals regulations. So if you're in a situation where the company is saying, oh, well, we don't have to follow the state limits on how far back we can go because we're under ERISA, you might want to think about or contact us because we may be able to see whether you're in a jurisdiction where they've upheld that kind of ruling, that the companies actually have to go through a lot more hoops if it's an ERISA plan. The next question is, how do you bill for no-show appointments for clients who use insurance? And the easy answer on that is you can't bill the insurance for no-shows. If you have a prior agreement with the client, and that's typically included, for example, in the informed consent documents that the trust provides, or the psychotherapist patient agreement that's in the HIPAA product by the practice organization and the trust, those cover that. But you can't bill insurance, and typically you can't bill government insurers either for missed appointments.
Alan, that just doesn't seem fair. I've set that hour. Somebody should pay for that hour. Why should it be my responsibility? Right.
Well, the point is your responsibility in that situation is to have an agreement with the client that if they miss the appointment, they've got to pay you. But most plans are set up so that, private insurance plans are set up that they pay for services. They don't pay for services that were not provided due to no fault of yours.
Now, it might be interesting for you to know that there is a CPT code for missed appointments, but to date, I've never heard of any insurance carrier paying for that particular code.
Yeah.
The next question is also a very tough one, Alan. How do we deal with this?
Yes. So the question is, how do you handle siblings who come in for relationship help when only one of them has insurance? And the easy thing on that is most private insurance companies have medical necessity definitions that require a mental health or physical diagnosis that you are treating. Most companies take the position that they don't cover treatment for relationship health, personal fulfillment, or other quality of life improvements. So you'd have to be in a situation where one of the siblings actually has a mental health diagnosis that you're treating, and the problems between the siblings are part of your treatment. And Tony, as a clinician, you may have further thoughts on that.
Well, the issue is if the relationship is affecting your client, it may be of some value to bring in the informant or the collateral to provide information. But as far as providing additional therapy for that individual, it would be outside of the contractual arrangement that you have with the insurance company.
Okay, the next question is, can an insurance company have a separate lower fee schedule for Obamacare plans, otherwise known as plans sold through health insurance exchanges under the Affordable Care Act, or ACA, have a fee schedule that's lower than for their regular plans? The answer is that insurance can and often do have different fee schedules for different plans, and that includes plans sold through Obamacare exchanges. In fact, it's fairly common for exchange plans to pay less and or have narrower networks. There's a recognition by HHS, at least during the Obama administration, that these plans would have to operate somewhat differently in order to remain financially viable. However, exchange plans are required to maintain network adequacy, but how that's going to be defined and enforced under the current administration is quite unclear, particularly given that the current administration is hoping to repeal and replace Obamacare.
Well, Alan, how about if we proceed with a series of also specific questions about testing? And specifically, let's start with, what about, can I interview and test on the same day? Based on my over 25 years on the CPT panel as an advisor and as a panelist as well, there is no information that suggests that these two cannot occur on the same day. However, your contractual arrangement with your carrier might limit those two events occurring on the same day, so it may be worthwhile for you to double check. If that's indeed the case, sometimes it just seems prudent. The patient is coming from far away, it's very difficult, that you're lucky to get them into the office or the clinic. Request some type of, if you will, oversight support that would allow you to bill that. There are circumstances where that seems clinically most appropriate, but you have to be careful relative to the insurance carrier. What are the pros and cons of using 90791 and 96116, and for that matter 118, to do the interviews before testing? Well, let's start with the following. 101, and of course 102, 118, and for that matter 119, and its related computerized testing codes are not interview codes. So do not use them for interviews, period. There's simply no two ways about it. Now, what about this one? 90791 versus 96116. And I've heard this one before, so I'll use this particular example. I prefer using the 91 code. Why is that? It reimburses more. Coding by reimbursement is essentially tantamount to fraud. You do not bill by reimbursement, or if you will, one pays more than the other. You bill for what you do. So if you're doing a psychiatric diagnostic interview, you bill 91. If you do a neuropsych interview or a neurobehavioral status exam, you do 116. Now, I will tell you that the psychiatric interview has been written to provide unusual robustness associated with the way that we do the interview. You can interview collaterals over different days and so forth, so on. That robustness is not as clear on the 116, but still you can bill over different days and so forth, so on. So I don't think one is necessarily better than the other. It just depends on what kind of interview that you're proceeding with. Now, this next one is an interesting question. In fact, we debated regarding changing the format of the question. Can we bill an office visit with 118 and 119, neuropsychological testing, administered by a neuropsychologist or PhD? Let's start with this one. These codes are not limited to neuropsychologists. If you are been trained and licensed to administer these exams, then by all means proceed accordingly with caution, obviously, as anyone should. The question is a little bit more complicated and regarding, and by the way, I should mention PhD or PsyD, and sadly, or maybe surprisingly enough, over 50 or maybe half of all medical specialties have actually been recorded to a bill for neuropsych testing. So we're not alone. Most medical professionals also have, at least from time to time, have billed this, although we're by far the most frequent biller of these codes. Now, can we bill them on the same day? Yes, I think you can. Again, it depends on the contractual arrangement. Remember that the 1-8 is for professional time, which may include administration and feedback, and the 1-9 is for the application of these tests using a technician. Keep in mind that the 1-9 is only for face-to-face time and not for the scoring of these tests. That's actually been included in the valuing of these codes. So it's something that you could find more information if you prefer on the psychologycoding.com website, which includes quite a bit of information about this and the difficulties associated with administering these two codes together or these codes together on the same day. That has been a real challenge, especially for those of us who have been Medicare providers. Can time spent administering tests by a doctoral intern be billed under 102 or 119, or working in collaboration with a licensed psychologist who's writing the report? Please clarify the difference between Medicare, Medicaid, private insurance companies. Well, Alan, I have to be honest. If I wanted to answer that question carefully, we should be here through the weekend, because it's not so simple. Because each carrier, whether it's even Medicare or Medicaid, or if it's Blue Cross or what plan and Blue Cross, really has different angles to all of this. But I will tell you that almost every insurance company is silent as to who is considered, quote, a technician. So we're really not clear about that. We are only clear in one carrier. And Alan, who is that? Medicare.
I actually don't know that. That is not, Medicare, yeah.
It's Medicare. And the reason for that is because they've challenged us. Because they say, we are receiving general medical education credit, so we're already training these students, and as a consequence, there's no reason why we should be getting money to train them and for them to administer the test. Well, for me personally, I'm eager to see where that GME money is coming from, or where is it going to, because it's certainly not going into my pocket or into my office or into my institution. So it's a bit of a challenge, but if you are working with Medicare, you have to be very careful on this particular issue. Compliance officers and audit folks will probably frown very poorly on the use of interns to administer and bill. Now, here's an interesting question. Can you administer and not bill? Well, here's a challenge. You might be underbilling according to some Medicare carriers. So we're working on this. We're trying to address, as you well know, Alan and many others in APA, especially PAPO, especially Doug Walters, we're working very hard with Congress to try and get the physician definition through. That would resolve this problem and give us finally access to the GME credits. But we got a ways to go on that one. So let's continue with our next slide.
Hey, Tony, I just wanted to add one. Tony, I just wanted to add one thing, which is that our Office of Legal and Regulatory Affairs has been working with the Education Directorate on a program to get greater reimbursement for work by interns, by psychology interns in Medicaid programs. We now have 18 states that allow this. 4 of them have been added very recently, and that applies to all types of billing by interns, not just in the testing capacity. That's all I want to add.
Yeah, thank you for pointing that out, because in many ways the Medicaid system is friendly to, in many cases, to interns, whereas the Medicare system is relatively unfriendly. And APA is very committed to making that happen. In fact, I think we have one postdoctoral fellow or congressional intern who is focusing just on that issue alone. So we're very committed to resolving this problem.
Correct.
Thank you.
Yes.
All right. Let's go on to the next one. All right. Am I allowed to bill service and for travel when I make house calls? What about the future? Well, unless you're doing forensic, you're not going to get reimbursed for travel. I wish that was different, but it isn't. As a matter of fact, the location of service bears no influence on the reimbursement rate at the Medicare level. Now, can I do something else? Well, I'm not sure what you could, but at this particular juncture, house travel or house service is not considered to be something that requires special billing or any type of reimbursement. Would you like to add any perspective on that, especially from the legal view? Alan?
Well, my main perspective is with private insurance, and private insurance certainly doesn't pay for travel time either.
I wish it was different because we need to go to people. In many cases, they can't come to us, but at the present time, we have no indication that that will change. Here's a tough one. And in fact, I received a question like this not long ago. I like doing evaluations that are 16 hours long. Why is my insurance limiting me to 8? Well, it actually comes from what we call the National Correct Coding Initiative, led by Niles Rosen, who is under contractual arrangement with CMS to provide, if you will, interpretation of these codes. Now, based on information that is proprietary and not clearly available to us in the public sector, they have chosen, in many cases, 8 hours as the limit, sometimes a little bit more, sometimes a little less. And then what happens is insurance companies decide, based on that, what they want. Some allow a little bit more, some allow a little less. But in this case, even though some of us know what these numbers are and we're bound by confidentiality to not share this information publicly, I will tell you that 8 hours appears to be a common number that folks are telling us that is the limit. Now, 8 hours for testing. It does not include other aspects, for example, 96116 or any other aspects of the evaluation. Tough question.
Hey, Tony, I wanted to add something on that. We haven't had questions like this recently, but a few years back we had a situation with in Massachusetts with neuropsych testing being limited by the Blue Cross company there, and they were applying proprietary guidelines to put hard limits on testing, and we are asserted to the Attorney General of Massachusetts that that's contrary to Massachusetts law, which requires care to be really based on the particular patient's needs. And so we were successful there in challenging that. So particularly if they're going for, if a private insurance company is setting the limit at less than what CMS is saying, that's something that we may be able to challenge. These things are a lot of work, but it's something that we could consider. So if you're running into a situation, particularly where it seems like a really unreasonable limitation, please contact us. We've seen over the years that insurance companies have been really putting the screws on psych and neuropsych testing, and we've pushed back in places, as we mentioned before. And on the last webinar, we've had a recent success with the neuropsych testing policy by Cigna and a challenge to the New York Attorney General. So this is something that we value the testing that psychologists are doing. And so if you're seeing what you think are very unreasonable limitations on that, contact us and we may be able to challenge them.
Let's go on to the next slide, which is more Medicare, and I'm going to go ahead and start focusing on a bit more abbreviated responses, Alan, because of our time factor.
Yeah.
How can you make sure 3.7 and for the other matter codes will stand up to audits? It's all about documentation. There are several options. The carrier sometimes provide it, the psychology coding, and APA PO website has some additional ones. Anything you'd like to add to that, Alan?
Well, actually, I hadn't even realized that this question was here, because I covered this a lot in my earlier answer to the question about how can you be ready for audits on 90837, and I went through the things about the things you should check for on that.
The next question is that it's a good one, and it says, what about more difficult codes? Let me change the word more difficult to less frequently used. The first one is the brief emotional behavior, and that's really intended for pediatricians, and the other one is the 408 code, which is a G-related code. My suggestion is that you stick to basic codes, and for that matter, to frequently reimbursed diagnoses as well. And the final one on this particular slide, I've been in practice for a decade. What things can we do better with billing to make more money? Well, I think one way to do this is build the correct code, document appropriately, and make sure that the return on investment is a very good one. In other words, what percentage of your bills are actually collected? And you'll find out that if you work in an institution, the reimbursement collection is relatively low excuse me, than if you work in private practice settings. I've often suggested that the number of feet that is between the point of service and the point of billing is related or correlated with the amount of reimbursement. If they don't know who you are and the billing is done far away, the reimbursement sometimes does not reflect the amount of effort you have put through. Alan, any comments on that?
Yeah, I was just going to say a similar thing that we've heard from some of our members is that, there's the advice that you should really monitor your billing, and it's helpful to have a billing service or somebody in your practice who can really keep on it. It's hard for a private practitioner who's just operating on their own to be treating patients and then dealing with the business. But, a number of our members, particularly the more successful ones, recommend that you really track and keep on top of what you are getting paid by private insurers and other insurers. And it really helps to have people who can specialize that so you can practice and they can make sure that the money's coming in.
And along the same trend, even if you're in an institutional setting, meet regularly with the billing department. Check your EOBs. What is the pattern? Where are you failing? What are the difficulties in reimbursement? Whether you have a billing system or not, it's your problem. Health and behavior codes. What's a 150 and 152? No, there's no such codes as 150 and 152, right, Alan? We have two more numbers.
Yeah, you're the coding guru.
Okay, so what we have to do is check out the practice website, the psychology coding, or the actual CPT, or for that matter, the insurance manual. There are two additional numbers so you need to be aware of, and you cannot use just 3 codes for anything. All right, let's go on to the crisis code, which turns out to be a bit of a crisis. Did you know, Alan, that we have codes in the CPT code book that are actually not reimbursed by insurance companies? How is that possible? Well, just because they're in there doesn't mean that the carrier will reimburse them. First of all, they're new. They're very difficult in the fact that it's a different paradigm. The whole idea of great intensity for work associated with life-threatening situations. So very simply, is that the insurance company has not migrated to this kind of thinking. That's where APAPO, your SPTAs, and your individual lobbying and educating goes forward. It's just a new concept that I think they're not quite ready to understand and, for that matter, accept. And how do you code for extended hospital visits with a client who, after an overdose, was hospitalized on a medical unit? First of all, regardless of code, there is no differential relative to location of service. That's number one. Number two, we are basically proceduralists. Here is a wonderful example where you might want to consider something like the H&B codes, like the 5.2 codes and so forth that we just mentioned. These codes provide specific information of being able to follow up patients in the hospital if you have a medical diagnosis. Let me give you a tiny background on the health and behavior codes. Those codes are essentially our E&M codes. Those are our follow-up codes for patients to have medical diagnosis. So a situation where somebody is now in a medical unit, may have some medical problems and has a medical diagnosis outside of the F codes, this is what you need to be considering. So crisis codes, educate, extended hospitalization, proceed with whatever you can from the standpoint of doing a procedure. So we have some questions regarding testing and evaluation. What code do I use for a 29-page psychological evaluation? I'm sorry, Alan, there is no code for a 29-page psychological evaluation because insurance companies don't pay you by the page or by the words or by the characters. They pay you by the hour. And the difficulty that you might have is that putting together a 29-page evaluation might require so many hours that the insurance company will not reimburse for that. Let me direct you to the work of Karen Postal and colleagues who have talked about developing reports that are very targeted, that provide information that allow for medical necessity determination, specifically what we can do to improve the body part. Just because it's thorough, doesn't necessarily, it's good just because it's thorough, does not necessarily mean that you will get paid. Any comments on that, Alan?
Advice I often give to people just in dealing with insurance companies is when you're dealing with overworked, underpaid insurance people, you aren't doing your PhD dissertation, if you can explain it in a page and you can provide later detail, but be brief, get to the point. That's my advice.
All right, let's continue with these next following questions in a much more defined fashion. What is the correct way to bill psychological testing on the evaluation and management codes? I'm disappointed to share with you that unfortunately 99205 is not one of the typical codes we get reimbursed for. Physicians sometimes can and do, but for us, we really have to live in the psychiatric code range or the CNS testing code. So this is not typical. And the next one is, I do neuropsych evaluations involving Alzheimer's, but sometimes the patients are worried. Well, you bill for the diagnosis you go after, not the diagnosis that you discover. So if you think there's ample evidence based on the physician referral to proceed with a full neuropsych evaluation, code accordingly. And if you, at that point, you find that maybe what you have is depression or adjustment disorder, from that point forward, you cannot provide additional neuropsychological services. If anything, you might provide psychotherapy or problems of that nature or procedures of that nature. All right, a few more evaluation codes. How should we bill for the following scenarios? The provider interviews the patient, psychometrist performs the testing, and the provider integrates previous patient records. That's a very standard situation with 55% of those of us that use technicians, for example, in neuropsychological testing. In that case, you use excuse me, 1.6 for the interview, the 1.8 for anything involving the integration of findings, and the 1.9 for the actual testing. Again, if you want to see a model, psychologycoding.com, I think about slide 100 provides some information regarding that. If the provider interviews the family, and of course you're welcome to interview collaterals, family, informants, and so forth, a psychometrist performs the testing and the provider performs the testing, the provider integrates. Same thing, except the testing by the neuropsychologist is captured under 1.8. Let's go on to the next slide, please. I don't know the answer to this one because I don't think that there's anything in the literature or the CPT system that talks about handoffs. We are proceduralists by design, and there are no codes for transfer of services. We do have something on telepsychology. Alan, could you tell us about that?
Yeah, generally speaking, and this is from our telehealth expert, Deborah Baker, generally speaking, there are no separate telehealth codes. You use the CPT code that best describes the service provided, and typically payers require the appropriate modifier, which is for audio-video conferencing, is GT. You use that with a CPT code. Again, the modifier that some payers expect is G as in Jerry and T as in Tom for audio,
so in essence, what you do is you provide the actual base code, which is a procedure such as psychotherapy, etc., interview, and then you put a dash modifier that allows it. Let me encourage you to take a look at the APA website that has very, very good guidelines for telehealth and specifically what limitations that you need to follow or be aware of as you proceed to make sure that these things are HIPAA compliant. But to make it really simple, in terms of telepsychology, you can do everything according to the CMS system minus testing. I think that will be coming down the pike, but not at the present time. All right, let's go on to what is that, Alan? I can't read that. So it reminds me of those things where they ask you to put in the code and you can't read it. What is that word? Change?
Change.
Whoa, what does that mean? Well, guess what? We've got a little letter from CMS saying that we have overvalued our services or misvalued our service, largely because it turns out that we had so much testing billed. And they said, it must be that since you're doing so much, we're paying you too much. In essence, this is code for, guess what? Let's look at the next slide. You've got to do something different. So we found ourselves in a very difficult situation where we had to go in front of the CPT committee or panel specifically. This is, excuse me, this is a group that I served for 8 years, and that helps define what procedure or what activity you can do, in many ways how you document it, and the resource-based system, or what software referred to, that values that. So we've gone in front of the CPT committee or panel, and they have said, hey, guess what? Your ideas are interesting, so let's move forward. However, it's not as simple as you request something, they give it to you, and life is that simple. It's a multi-year process, requiring a tremendous amount of effort, providing empirical information, a great deal of diplomacy, a fair amount of luck, and then if that happens, then we go to the next slide. We then get it printed in a CPT process, usually a year or so later. So if we're doing work at the present time, this work will then become used in 2018, or if things don't work out so well, maybe 2019. And the codes are found in 3 main categories you see here. And finally, as we go into the next slide, we then have to present these codes to the RUC process. And if it looks like a very difficult process and you're having a hard time following that slide, it is difficult. Imagine that we're asking 130 other health specialties to share 16 or 17% of the gross domestic product with us. Or in essence, could you give us a bit of your pie so we could eat a little bit better and provide services to others? This is a challenging, arduous process that requires a great deal of understanding. If you get to be part of it, lucky you, you will help set the foundation for eventual reimbursement. But if you do participate, please, please, read carefully whatever instructions are sent to you by whomever, and we look forward to working with you as we help CPT develop the appropriate codes that reflect who we are, what we do, and how we should be reimbursed. Next slide. All right. So I don't know who these 2 gentlemen are in this picture, but I do see on top it says question and answer period. So how about if we turn it over as we have a few more minutes, and let's hear what your questions or concerns. We look forward to hearing your support, your questions, whether they're avocados or tomatoes, we're ready for them.
All right, we're having trouble reading these. These come out in tiny script, but let's try this one. If you typically conduct 10 units of 96118 for a comprehensive neuropsychological evaluation, and some plans cap at 8 units, what can be done? Well, I guess you sort of covered that, Tony, but did you want to add anything more to that?
In many ways, your contractual arrangement really defines how much or what you can do. If you find yourselves doing a situation where your contractual arrangement forces you to engage what you consider unethical practice, then you need to move forward aggressively to try to resolve that problem. But if you sign a contract that basically says 8 hours is what you get, 8 hours is what you get. Now, if you want to try and resolve this by explaining to the patient that they may be responsible ahead of time and things of that nature, maybe, but there's some kind of legal requirements you may have to discuss with other parties to make sure that this is acceptable according to the carrier contract that you have signed.
Okay, here's a good question. Why can't we form a group practice and negotiate reimbursement like medical groups? So this is actually something that practice organization and within it, legal and regulatory affairs has been working a lot on. And there are basically 2 ways that you can do this. One, you can just have a larger practice. You can just grow your practice, combined with other practices. And a large single practice has the ability to negotiate rates without worrying about antitrust. The other thing you can do, a lot of psychologists don't want to have to join up with other professionals. The other thing you can do is you can form something like an IPA, which a lot of people are familiar with, or an MSO, Management Services Organization, which is sort of like a more robust IPA, as our outside counsel refers to it. It's IPA on steroids, but has a lot more flexibility. But these kind of structures allow independent practices to come together and collaborate, and then if they're doing the right things, then they can also negotiate as a larger group, which gives them greater bargaining power. There are a couple of ways there are a couple strategies you would need to follow in order to meet the antitrust laws or avoid getting in trouble with antitrust laws. And one of the most common things we recommend would be to do clinical integration. And we have an article on that. If you just send an email to that number, we can send you the article on the clinical integration so that a group like that could jointly negotiate for higher reimbursement.
Sounds good. Let's take a couple more questions, Alan, and then we have 3 or 4 slides to wrap up our webinar this afternoon. Can you read from the screen?
Okay, yes, sure. This is one it's an interesting one. Dr. Puente stated earlier that the standard session that most use is 45 minutes. Is this just an insurance company assumption, or is there data that supports this? I've asked many colleagues, and everyone is using the 55 to 60-minute hour, or 90837. So, Tony, you can start. I have some thoughts on that, too.
All right. Well, first of all, let's explain that this is how we basically billed until very recently. There was essentially no 60-minute code until the new psychotherapy codes emerged a couple of years ago. We have to thank many individuals for those codes, including Randy Phelps, who heads up the CPT section of APAPO. However, it is not the standard code. Also, in terms of Medicare, we cannot get good data to determine whether this is the case for private carriers, but the last set of data that we were able to look at, the standard code for psychotherapy in Medicare still remains the 45-minute one. Yes, Alan?
Yeah, so interesting thing is that I mentioned earlier there are strategies that companies have been using to try to get psychologists and other mental health professionals to use 90837 less. An interesting one is first Anthem was using that, and then Highmark Blue Cross Blue Shield in Pennsylvania was using this, is having consultants send these letters which sounded very ominous that said, essentially Big Brother is watching your 90837 usage. Here's the average usage by the company, and here's where you are. Now, we actually successfully worked with the companies to clarify that they are really just checking that people are appropriately billing 90837. But the interesting thing is that these letters actually gave us a window in on, at least for those companies, how often people were using 90837 as opposed to the other therapy codes. And for some of them, it actually was pretty high. I think for one of them, it was over 50%. But it's, particularly for private insurers, the data on utilization of different codes is very hard to come by. So that's actually, we sort of appreciated that they were sending these letters, which gave us a good window on what was happening with those plans. I do talk to a lot of members who are using 90837 a lot, some of them almost at 100%. And as I said, if you're doing that, just make sure that you're recording your start and stop times, and you may also want to be, coming up with a rationale for why you're seeing patients longer. But if you're following the CPT guidance, recording your start and stop times, and following any company guidance, you should be able to use it. Any more you want to add, Tony?
Yeah, why don't you find the next question in the interim? I'll share with you that many people have said to me, hey, guess what? For 25 years, I underbilled. Because in reality, I was actually providing 60 minutes. And keep in mind, it's face-to-face, not total time. It's face-to-face activity with the patient. So in many ways, I've been underbilling for 25 years, and therefore, finally, I'm getting reimbursed for the services that I'm currently doing. Alan, what's our next question here?
Okay. This is a new this is one that I haven't come across before, but I have some thoughts on that in a broader context. Can out-of-network reimbursements be clawed back by an insurance company if the patient pays and files the insurance themselves? This is something we've seen more often where people who are out-of-network are saying, why do I have to respond? I don't have a contract with the patient. I would expect in this situation that the clawback would go to the patient who collected the reimbursement. But often what happens in this situation is you just have a triangular relationship where you may think, well, I don't have a relationship with the insurance company, so I'm not going to respond. But you do want to be mindful that your patient does have a relationship with the insurance company, and you always want to be mindful of not, having their claims denied or things like that. I just have not dealt with a situation where the clawback for out-of-network reimbursement is going to the psychologist unless it's set up so that the reimbursement is assigned to the psychologist. And in that case, I would have to think about that, but I would just mainly in that case look to the legitimacy of the clawback request. Often clawback or recoupment requests are based on the fact that the patient was no longer employed by the company that insured them at the time of the services. Why it's so hard for companies to keep that data up to date, I don't know, but that is the most common reason for that.
Let's take one more question, Alan, before we begin to wrap it up this afternoon.
Okay, I'm looking for a lot of these we've covered before, so I'm looking for ones. There's some more on home limits.
And as Alan's doing that, let me encourage you, if you have additional questions for you to write practice@apa.org. We'll do our very best to get back to you. And as CAP has requested, and we will do our very best, we will provide responses to a large sample of your questions on the APA website, APA-APO website in the near future. Until then, please bear with us. It's hard to answer several hundred questions, but we're delighted to hear of the enthusiasm that you have had for these particular seminars. Alan, one last question.
Okay, could you please review more specifically whether and what code to use for self-report questionnaires, outcome measures, etc.?
Well, if you have an outcome measure, in other words, we have a numerical piece of information, I think something along the lines of 101 or 102, or for that matter, 118 and 119 would be appropriate. Again, let me emphasize, you have two activities in terms of diagnostic events. First of all, you have the interview, and then the second one, you have the testing. As long as you have something that is not numerical, that's qualitative, and emphasizes a lot of interaction between two parties, and including the review of records, that would constitute an interview. If there's something more structured, or even the administration of tests like the projective test, that would be find its way into the 102 or 118. So with that, Alan, we have some comments that we want to share with you, including the next slide, and maybe you can take this one over since you are one of our esteemed APA-APO members.
Sure. As I've sort of indicated before, the APA Practice Organization assists members with health insurance and managed care issues involving private and government insurers. This includes Medicare, Medicaid, TRICARE, which we've just done a lot of work on with a recent rate cut in TRICARE. Issues include billing, contracting, restrictions on care, parity, and HIPAA compliance. Our approaches range from collaborative resolution, something we've been working on a lot lately, and with the enlightened companies, that has actually worked well, to with more intransigent companies, complaints to regulators, lobbying federal and state legislatures, and, as always, lawsuits. If you have problems, please contact us at that email that I gave you before, practice@apa.org. It's right at the bottom of the screen.
If you want to learn additional information, we encourage you to be a member of the APA-APO. This cannot be done without your support and without your membership. It's very critical for the welfare of the profession of psychology. And if you do so, you can look up the APA-APO website, the Good Practice newsletter that comes out, or actually short magazine, and one particular one that just came out, which is fascinating, is how do we actually value these codes? Because sometimes people say, oh, why is it we get paid so poorly? Part of it is basically has to do with a survey process. You want to find out how that your voice translates into your reimbursement? take a look at that particular interesting bit of information. And if you have additional resources, the APA Practice Central.org, the website that I've maintained for a number of years, the Psychology Coding website. These are two good ones. And of course, the AMA CPT code book is also a good one. Let me add, Alan, if you don't mind, that people should be reading the websites of the contractual arrangements that they have. And despite the fact that they don't have to alert you to changes, those changes are posted from time to time. It behooves you to keep up with as many as feasible, certainly the major ones that you're associated with. Any others that you would like to suggest, Alan?
Well, the one thing I would say is for private insurance, most provider contracts do require them to give you notice of significant changes. I also just want to jump before people get off the line. We want to remind folks to stay online to take the survey. We're very interested in your feedback. Just tell us what Tony and I can do better in the future to make this webinar more responsive to your questions and your needs. Thank you very much.
Thank you for joining us again. We look forward to seeing you at the APA convention. Look forward to making sure that you become a member, if you aren't already, of your state association, APA, and most importantly, the practice organization. Thank you for your support. We look forward to working with you to serve our constituents. Have a good day.
Thank you, everyone.